Uh-oh, Melody's here.
So, Nick, what
Melody's
are we
about,
talking about today?
oh, I don't know. Hold on. I lost the slides. So, because you love to trigger me in some way, shape, or form, we'll do everyone's favorite. So I think we talk a lot about the initial asthma or obstructive stuff. Oh, they're obstructed and everyone's like 8 cc's per kg and make the rate 10 to 14 and make sure there's no auto peep. But what about a week later and you're still the same? And no matter what you do, things are still not better or not moving in the direction you want. Do you stay the course? Because I think we talk a lot about the initial management of this stuff, but we don't talk about a week later or 2 weeks later or 10 days into the disease course. So I figured we'd do that. So let's say you have someone, Melody, and they're on Heliox, which I don't love, to be honest with you, because I don't think it does much. But nevertheless, so it's a 65-year-old lady, past medical of whatever you want, but has asthma, gets intubated on day zero of hospital stay. High airway pressures, et cetera, doing all the things. But now it's day seven. So now you're called to the bedside because the patient's hypoxic. And these are the pressures. This is the waveform. The blood pressure is what it is. The patient's been sedated to the gills for over a week. So the patient's not interactive at all. Like the RAS -5, you stimulate them, they don't do anything. But as much as you want to will this to be better, it's not any better, right? This isn't any better, right? And all of this stuff, like this, no matter what we want to say, this could be day zero, it could be day 50. It's not any better. And I guess the question is, Melody, do you ever change the goals, right? Because won't someone say to you, oh, Mel, we've been doing this for a week. It's not any better. Like, we really need to do this. Are we always sticking to our guns and saying this is the stuff that we have to do? I guess is what I'm trying to ask.
That's a great question. First off, I think what we need to do is just back up and talk about what you just circled. So I think everyone's going to by now, after following me
Do
for
you want me to
today's
leave it?
auto peep. No,
Okay.
I think we're going to recognize that we are having auto peep. That's that second smaller circle that Nick drew. But the thing that he circled, the larger red circle, I think what I'm interpreting and I see in this waveform is that our peak expiratory flow is very low. If you look at your y-axis, is that a 60?
This is 60 here. So I don't know what this is, meaning the actual, right? But
I
the
know, I
high
think it's the scale, but it's probably so their peak expiratory flow is probably around what, 45-ish? What do you think?
45-ish, yeah, I would go with that. Yeah,
Yeah.
45-ish is fine.
So it is a little lower. It's not terrible. It's not as bad as some of the asthmatics you can have, but still definitely lowered. But you would expect a little bit more than that. So in this situation, we're definitely seeing that the patient has prolonged expiration. You can see in our end title that we're still not getting to a plateau. You still have the classic shark fin presentation. So we're still
Mm.
dealing with bronchospasm. And oh my goodness, I could go on a sidebar about the end title waveform and
Go on, go on a sidebar.
so, everybody, I hope you see your end title is currently reading at 72, but I want you to ask yourself right now, looking at this waveform, is that an accurate number? And I hope you're going to say, I don't know, is it accurate? And I'm going to tell you right now, it's not because we're not getting to a plateau. So this
Mm.
is erroneously low. His patients and titles, if we actually got to a plateau, are going to be higher. The vent will always, or end title will always report a number, but if you're not getting to a full plateau, the number that it's reporting is still showing dilution with dead space, and you haven't gotten to full alveolar values. Nick, would you agree?
I agree, but I'm not an end title expert, but that it is shark finning, and I pointed that out because when I saw this, I said, hey, we're not better, right? We're not, no matter what we want to say, it's been a week, it's not any better. So I think if we were waking the patient up doing X, Y, and Z, like, you're going to be right back in your same issue, which is bronchospasm, auto peep, etc. The question I have for you is though, and correct me if I'm wrong, even when we get to a plateau, right, that still could be less than what the actual alveolar CO2
Yes,
is, right? Is that right? Okay. All right.
absolutely.
So
Go
this
ahead.
is another thing, which is like, and I think you do, because I think you said it before, but you monitor the end title on the vent, meaning on the servo, we can plug in the thing and it gives you the real-time end title. And I will go to the ground that this isn't helpful. The breath end title is helpful and what it alarms, so maybe that's helpful, but there should be other things tipping you off that you're not ventilating, I think, is my opinion. And I just think it's just more numerical data garbage that we see because the end title goes up. I think it goes up in another part of the video. It goes up to 80 or something. And it's like, what does that really mean? So I don't know. I just think the waveform is nice. Don't get me wrong, because it's classic shark fin, as you pointed out, for obstruction. But I don't know if it's really clinically doing any heavy lifting in the ICU situation. Now, you want to be
Yes.
in the air is fine. Obviously, cardiac arrest is fine. But for the intensive care unit, I don't know if breath by breath end title is really like the cat's meow. You know what I mean? I
So
don't know. I
Let
feel like you want
me
to argue with
play
me, which I, go
devil's
ahead.
advocate for you.
Go
I'm just,
ahead.
because again, coming from a bit of a transport background and also places where we don't necessarily have all the bells and whistles and tools. So, first of all, throwing the bone for the transport people. If they don't have point of care, this is the only
Right.
thing they have. Now, yes,
Agree.
you must understand where end title falls short and all of the things that are going to drive that value off. But
Right.
once you do gas and once you correlate that value, if you are getting alveolar true plateaus and you know tracking, if you notice that your end tidal is going up and down, you can then infer that your PCO2 is going up and down. So let's
Yeah.
say you correlate, you know that your gap is a gap of 7. Your end tidal is 7 lower than your PCO2. You are making changes to move your pH. If you notice that your end tidal starts to decrease, your PCO2 is decreasing. Now, yes, if your VQ matching improves, if you all of a sudden recruit, if you're using PEEP to your advantage in a different patho, not this patho, then
Right.
that might be a situation that you want to recorrelate because you could then have a different correlation as you start to get better matching with your dead space decreasing in the alveoli. Your alveolar dead space has decreased. But in that
Right. But just to be
case,
clear, that you're talking about volumetric capnography now, which is different, right?
no, I'm not. I'm talking about standard capnography that you have right here. That if you
Okay.
see your end tidal tracking down or up, again, you're still going to have to do a gas later on to ensure your correlation remains accurate. If you are making multiple changes, if you're
Right.
noticing end tidal trending a direction, you can then infer your PCO2 is doing the same trend. So it might mean that you could save yourself a gas for the first 20 minutes and maybe do a gas at an hour versus doing
Right.
serial blood pulls because you're moving your pH to a certain direction. Do you know what I mean?
I know exactly what you mean. And I think I'll be honest with you. When it's on, I do notice it. And when it changes, I do notice it. But I think this quantification bias is an issue because I think it's more like when we make things normal. I think everyone was approaching the situation like it's 72, it's abnormal, it's going to be abnormal. We're allowing for permissive hypercapnia. But when we are intubating like other patients or have other pathos, as you call it, we want to normalize the number. And I think like, from my goals perspective, and I think your goals perspective too, I just have a floor, I think, which is 7.2. So I'm good with almost everyone being a scooch permissively hypercapnic if it's going to allow for smaller tidal volumes if I need them and less auto peep. Now, situations we can't do that, right heart failure, brain injury, et cetera. But the second thing is I like that and I think I can speak for you and say we agree with this, is that I like when patients are breathing. So I just let them control their pH and just sort of drop the rate and get out of their way. Do you know what I mean?
Yeah.
So I just don't know. For me, on the day to day, I don't know how much end tidal really helps me. I definitely don't think it's helpful here because it just is like it's just going to be not what you want it to be. And as you mentioned, it's much higher than that. I think in this situation it was in the 90s or hundreds, honestly, when we checked the gas. So it's like doesn't I don't know how much it
You,
really matters.
you could extrapolate it. And I would bet if you played the video on when you noticed that the end tidal went up, it's because you had more of a plateau. The reason that end tidal I find for asthmatics is actually very useful is in some of the times when I've had to consult on these severe patients, one of
Right,
the things that we'll use for practitioners that are maybe a little bit junior and are not necessarily trusting themselves if they're getting a full exhalation is I will
right.
actually coach them to say, are you getting a plateau in your end tidal?
I see what you
And
mean.
and they can recognize that. And as soon as I ask them that question, they're like, "Oh no, I'm not. It's still just a shark fin." Then I'm like, "Oh,
Mm.
this is telling you you're not getting a complete exhalation." And that then helps them make that brave jump to say, even though even here, if they're not,
I hate when you make good points and then I have to agree with them because I hate doing that. But
there is value. And hey, for the rare cases that you're doing a manual decompression, keeping your end tidal on your patient as you're doing a manual decompression and watching for that flattening, super high yield.
that's a good point. No, God damn it. All right, Melanie. I will. Well, nothing you, but the sepsis lady doesn't need end title, right? That's going
Yes,
to be
it's not for every patient. I love going to end tidal for those more long-term ventilation patients that their patho's pretty much gone. You're in the weaning phase. You don't want to do serial blood gases. You might do one a day just to correlate, and then you're just watching as you're doing minor changes. Because at the end of the day, we're probably not going to swing our pH too much. Great. I love end tidal for that patient. Saving blood draws and not having to do gases as routinely, cool. For
touche.
acute, very quick, rapid changes where I know I need to make massive swings in ventilation, I love using Untitled for that case to just
Yeah.
know that I'm moving in the right direction to decrease having to do a gas every 20 minutes. But I still am correlating quite frequently to make sure my correlation is the same. And it's just going to ground me. And then I use the shape a lot to direct my ventilation.
Man, another waveform to know. So you're always working, but you are actually physically in the hospital and you get here to said screen and said situation. what are we doing? What's our number one priority, I suppose, maybe might be a better way to think about it.
Oh man. First off, I would want to do a full review of is the patient actually being optimally treated medically? Like,
Okay.
because I do have to say that I do find after that very first initial phase, sometimes they're falling behind bronchodilators and all those treatments, and they're not necessarily treating as frequently as they could be. It happens. But I would really look to see because in my gut, I am
Yeah.
not letting the patient ride with auto PEEP. I'm
Right.
not doing that. I am going to stick to my guns and want to go the obstructive route. And in this case, drop my rate immediately and
Hmm.
get this patient a bit more optimized. And this
Okay.
would be when I would lean on my ICU physician on what their suggestion is for this ongoing, not resolving. But I would want to stick to my guns because for me, you can't get air in until you get air out. And this patient
Okay.
isn't ventilating appropriately, plus having dysynchronies.
Oh, so even though the patient's very sedated, there's still the synchrony, meaning the patient's interacting with the ventilator? Is that what you
Yeah,
mean?
yeah.
Okay. Where do you see the synchrony at?
It just is off the screen now, but you can see that little blip at the very beginning of the waveform. There's one there too.
Where? To the right?
So at the very beginning of the x-axis, the very beginning,
Uh-huh.
there's a little blip that would have happened after the complex. And then the
Okay.
last breath on the screen, you'll
Yeah.
see right after inspiration on your flow time waveform, the waveform
Uh-huh.
pulls up. It looks like, I would say off the bat, it looks like a cycling issue. That's my first gut reaction.
So what you're saying is right here is a cycling
Yeah.
issue
And you can see at the very beginning, there was another cycling issue there as well.
in the beginning of the breath?
On the beginning of your waveform screen, at the very beginning,
Oh, okay, got it. It's
tell,
this we're talking about,
yes.
right? This third one. So we have a cycling issue, which I agree with, obviously. Then the other thing is, do you think, I guess the question is, like, the pressure curve, should that resemble the volume? Do you see how it sort of resembles it? I almost can't even tell the difference between the two.
Definitely not. And actually, sorry, Nick, I just want to check our eyes here because it's the servo and I
Okay.
find it's difficult. Are these breaths
Really?
controlled? Is it a reverse trigger?
Oh, that's a great question. I don't think this one was. I didn't see a little lungs pop up. So we can
Then it
do
would
this
be a
though. Hold on.
reverse trigger.
It would be a reverse trigger, and that would comport with what our, so
Sedation.
let's see here. Yeah,
And
with our
see, guys,
sedation.
this is a great little pearl, though, because here Nick and I are two experts looking at waveforms and recognizing that a lot of dysynchronies can appear the same. And sometimes you have to take a second, and your initial gut reaction might take you down one path. And hey, you could always try to fix it. But when it doesn't resolve, or with a little bit more investigation, you could be like, wait a second, no, I'm going to reclassify this. And I think that's what I just
So
did in my head. It looks like a cycling issue, but I'm like, no, these are control breaths.
so I don't see a little white line here, and I cropped it
Yeah.
out unfortunately, so you can't see the lungs, but it doesn't look like it's a assisted breath. It looks like it's a controlled breath. And then at
Yeah.
some
So that would
point,
be reverse trigger.
yes, and I think a point here is when the diaphragm activates because it pulls down that pressure curve, and then it
Yeah.
continues through. And then the worst thing that could happen is, I think if you just had a little bit more mustard on this, it would trigger a second breath, and then we'd be even worse. And
A
I
little
think
bit more mustard.
a little, you like that one? So I think
Yes.
the this issue, right? Because maybe someone will look at that and say, well, your dynamic compliance isn't bad. Your dynamic compliance is bad, meaning you need more pressure to change the volume from the more peak pressure to change volume, right? As dynamic compliance versus static, which sort of infers that you have poor compliance. So how does this comport with having asthma? And I can only think of one way that it comports with having asthma, right? Is that you have a ton of auto peat most likely that's driving your compliance down. So a lot of things suggest that you have a number one compliance issue, but also an obstruction issue. So
Can I pause you there and just get you to back up a little bit? Because I think the
yeah,
difference between dynamic compliance and static compliance, I explained it a bit differently, but I want you to
okay.
say again, what is dynamic compliance?
So dynamic compliance, if I wasn't mistaken, so static is plat minus peep and then volume, whereas dynamic, I believe, is peak minus peep and then volume.
So here's my counter argument for this patient and asthma. And I'm not counter argument. It's explaining the same thing, but I throw out dynamic compliance completely when I'm dealing with an
Yeah.
obstructive patient because what you're dealing with here is you're essentially looking at the volume delivered to the system with the pressure that you're delivering to the system, meaning the airways are involved. As soon as you're doing a static compliance, you're doing a zero flow state, meaning you're not looking at airways. You're taking the airways out of it and you're
Mm-hmm.
seeing the volume change per the pressure that got to the lungs. But here, this number is erroneously going to be low and obstructive no matter what when you're dealing with a dynamic situation with the airways involved
Mm.
because you're having to apply so much pressure to overcome those airways that ends up looking like, oh my goodness, look at all this pressure for no volume. But really, it was all airways, right? Is that
So what you're saying is that it's a resistance issue. Could be a resistance
correct?
issue. So it could either be a resistance issue or a lung parenchyma issue, whereas
There could be a
static
combination.
or a combo. But just from a we're looking for sort of philosophical standpoint, because we don't have the airways out of it, it could be either an airway or lung issue. Could just be purely an airway issue, right? I guess if you have some big if you had some big goober in the tube, your dynamic compliance is going to be super duper low. But if you suck that goober out, then we're going to be good, right?
And
Okay,
it's really like when you think about it, honestly, semantics. It's the same idea as if you look at dynamic versus static compliance, it's the same idea as looking at your pips versus your plats. If you
right.
notice a massive difference between those two, then between your pip and your plat, then that is telling you that it's all airways. Same thing with if your dynamic compliance is super low and your static compliance is high, then it's an airway issue. If they're both super low, then you're dealing with a compliance issue.
Right. No, perfect. And I don't, I guess, well, I guess they can't, the servo can plot, or any event, I suppose, can't really plot like a static compliance on a breath to breath basis because it would need to do a hold, which I guess it could do if, right? It could do it, but I don't, do some of the events do that, plot static compliance too, or no? Do you know? Does it
Uh,
Hamilton?
I,
I know that the T1 does all that funky stuff to try to get the compliance, right?
So the
Whatever
T1 does
I forget.
report the CSAT breath to breath, but it
Hmm.
is a calculated one with the equation of motion, which again, if it's a passive patient, it does a pretty good job. But as soon as the patient's active, the wheels fall off the bus.
Interesting. All right. So yeah, I'm not letting you get out of this though, Melody. What are we doing? What's your like for so of course it's perfect medical management. I'm doing it. The patient's on bronchodilators, they're getting a bunch of steroids. I didn't start the Heliox, but I also didn't take it off because I don't think Heliox does much. But we're treating the things, we're doing the stuffs. But now we still have this issue, which is at this point, well, I guess there's probably two. It's a patient vent interaction issue, which is like the reverse triggering stuff. And then
Yeah.
so it's actually perfect probably because reverse triggering is such a pain in the ass to take care of. And then there's this obstructive physiology still. I don't remember what the auto peep was. We can make it up though. Let's say that the total peep was like, I don't know, 15. So there was 7 centimeters of water auto peep. And this is what we're at here. So where do we go now from here? What do you think?
My gut would be to stick to my guns and go obstructive physiology and drop the rate, but that would be where I would go. I think I would take a wander in the chart and see how we got here with the respiratory rate higher and even the peeps up a bit as well. And is
I
there
could
another pathway that we're treating as well? I would definitely want to investigate that a little bit before I fully went rogue, but my gut would be to resolve auto peep and
I could tell
also
you how we got here. So we started at a rate of 12, and on a rate of 12, the auto peep was zero. The ventilating pressures were much better. That was yesterday. So to liberalize the patient from the ventilator, we started to increase the rate a bit. You might ask me, how is that liberalizing? And I'd say I agree, but nevertheless, that's what was chosen was we want to take the patient out of this much more deep permissive hypercapnia and then start to take some of that CO2 away. So we chose to increase the rate. That's how we got to 16. But when I come in the
okay.
next day, and when I say I and we, this is all sort of in time past. I don't even remember when it was, but I'm just sort of, I remember the very vague situation. Because the thing that struck me the most about this, honestly, is that I think it's a discomfort of status asthmaticus as like a pathophysiologic state. Because I think everyone is scared of it. And I think rightfully so to some degree. But I think that it leads to either us too quickly switching the goals or switching what we're doing, or really not. Because and this is a question to you. If you have a bad status patient, what do you take as the patient's much better? Is it the peaks are much better? Is it, do you get a time constant every day and see, is this better? Do you wake the patient up and see how they're interacting? What's heralding to you that the patient's much better? Which
Yeah,
I think is
I
actually a good question because I don't think that's really been delineated by anyone, right? Like, what tells us that this patient in status asthmaticus is better?
for me, it would be noticing that my exhalation is occurring sooner and that my
Hmm.
resistance is lower. So
Okay.
first it's flats narrowing, and then also my expiratory flows increasing, and then exhalation occurring faster. So when I'm
So,
noticing that, then I'm saying they're better.
so is it like a numbers thing? You get the numbers and are like, oh, the resistance was,
It's most,
or
I would
just
say
like a
mostly waveforms. I would say mostly
waveforms.
waveforms
Okay.
directly. Like my
Okay.
time constant directs my initial settings. And if I'm noticing gas trapping, that's where I go. And I know you do a time constant every day, which is great as well. Not a bad thing. I probably could do that. But essentially, then at that point, I'm just looking at my flow time exhalation to
Hmm.
see. And if I'm getting back to zero and staying at zero, I'm like, ooh, we're getting better.
So
We're
you, all
seeing
right,
air
got
improvement.
it. I see what you mean. So you want to see it get to zero. So then, which is fine. However, we sort of decide better is better. So then to sort of, because another thing that I think we don't think about enough is how, we probably do this another day, but how do you liberalize from low total volume and ARDS? I think I start to give more volume, right? Because the pressure is much better. I start to lift them up by giving more volume and then more freedom in the form of like a respiratory rate is sort of my approach. But for this patient, how would you liberalize this patient from the vent? So let's say not here because this is better. This is actually probably much worse or just as bad. But if let's say the patient was better, would you increase the rate? Would you increase the volume? Would you just tell them to wake her up more and let her be more interactive? Because I think the thing that I want to highlight is I think the problem here was she looked good on 12, right? The pressures were good. But as soon as she started to get more tachypnic, the wheels fell off. She started auto peep, and it was like, it was a nightmare. You know what I mean? So she looks good on 12, but you get to 16 and forget it. We're back to where we were. So to me, it's not better. I'm saying because she can't live breathing 16, which is also my issue with patients with emphysema. So if we intubate, sadly, if we intubate a patient with emphysema and I get their time constant 1, and I don't think there's a lot of reversibility, that's going to be tough to get them off the vent, right? Because if you, even with like the best eye time, the rate can't get higher than 18 at the most. So you're going to have a tough time negotiating the rate and not auto peeping in the meantime. You know what I'm saying? Does that make sense?
Yeah, absolutely.
So anyway, I know I asked you a lot of questions. The first one is, how would you start to liberalize the patient with obstructive lung disease from the ventilator?
And caveating that is not this current patient we're looking at, but I would most likely, once I'm seeing that we're having time in between exhalation before the next inspiration, I honestly, as long as our volumes were on the larger side, so that wouldn't inflate their respiratory rate abnormally by restricting them with low tidal volume, my first move,
Right.
if my volumes were at the 8 mils per kilo range, would be to just lighten and see very gently and see if what are they breathing now. I wouldn't want them to get tachypnic, but let them start to participate and maybe trigger. If they start to get tachypnic, then we need to potentially put that sedation back on. But I would go that route. I would see if they would be able to start to trigger and maintain their breaths at a rate that's reasonable without causing auto peep and then getting into that vicious cycle again.
What about if the patient's coughing a lot as you do this? What do you think about that? I'm sort of setting you up for this because I have a thought about it, but I want to see if we agree. And this isn't planned, so I want to see if we really agree. You do this stuff and they're coughing all over the place, and you're getting up all this thick secretion junk. What do you?
That's a good thing.
It's a good thing, right? That's what I think too. So what I try to tell the residents, RTs, and everyone is like, asthma is a disease of the small airways, right? Those they plug up with mucus, and then you obstruct and all that stuff, and they're swollen. To me, when they're coughing this stuff up, that's good. That means the airway's open and you're getting it out. So the thing is, like, when we start to lighten them and they have coughing and the vent's alarming and it's like a whole drama situation, I still go back to the waveforms and make sure that they're the same. If they're the same, then I'm not really worried about it. You know what I mean? Because that means that the airways are opening and the inflammation's going down. That's what I want. I want them to cough and get that mucus out. You know what I mean? So, which I think.
So my question back to you then, because I know
Yeah,
as a bedside nurse or even as an RT, it's
yeah,
hard at the bedside to delineate, are they coughing
yeah,
on the tube or are they coughing because
of course.
now that they're coughing, the vent, as smart as ventilators are, it doesn't respond well to coughing. It freaks out,
Right,
it high pressures,
right.
then the patient's not getting volumes.
Yes,
Then they
yes.
get into the cycle of they're not ventilating well, then they get tachypnic, and
Yep.
all of these things happen. So what would be a method that you would employ to allow them to have the ability to clear their airways and cough and do all the things we need them to do without having them completely spiral into the world of bad?
Take the tube out. No, that's right. So to me, asthma is like this magic moment when when it breaks and it's broken and then they're doing that, then I'm super aggressive getting the tube out. Do they pass SBT, SAT? Get the tube out. Because you can clear the patient can clear their airways better than we can. Now, I don't know if you're trying to goat me into like
No.
3% or NAC or something, which is those are all bronchospastic. I hate them all, number one. Number two is sure, chest VT and suction and I don't know, Mucinex, which doesn't do much, but maybe it thins it out. But I think the overarching theme is once they're broke and they're coughing that stuff out, that's the time to get the tube out. Get that tube out today. Because unlike pneumonia, asthma is when it reverses, there's no longer a need for the tube. You know what I mean? Whereas with pneumonia, your pneumonia could be better, but since the lung is completely trashed from the infection, you have this lingering compliance issue you have to deal with. So then you have to negotiate, can the patient breathe on their own and that kind of stuff with that compliance issue, which increases their work of breathing for any amount of volume, right? As a work of breathing situation. But once you take care of the resistance issue in asthma, it's time to get the tube out. So get the tube out that day if they pass. So that's what I would do, honestly. Otherwise, you're kind of stuck. I don't know, suction, Mucinex, chest PT, IPV, which does nothing. Get them out of bed.
They pass an SBT though if they're coughing too much. Just thinking
Being like,
in the
yeah,
shoes of the bedside nurse, and the
Yes.
RT that has a table of numbers that they have to see every
Right.
box be checked. And I'm
Yeah.
playing devil's advocate for them because I know that there's going to be people at the bedside that are
Yeah.
going to
No, I
struggle
know.
with it.
And this is so I was talking to someone else about this. So extubation is so much harder than intubation. So I will tell you when these situations happen, I don't leave. I'm there. So if you're a physician or an APP or whoever, this isn't the person that's going to check the boxes. They're never going to look
Yeah.
good. They're never going to be awake, give you a thumbs up. Hey, I'm going to get this tube out. They've been sedated to the gills for 2 weeks or whatever it is. They're probably delirious. They're probably weak. But you have to figure out, and you, like the collective you, like me, the RT, if they're breathing 24 on an SBT and pulling good volume and they don't look like they're auto peeping, but they're coughing like the Dickens, get it out, right? If it's sort of borderline, I just take it out because I could just put it back.
Yeah.
Because no matter what resistance it is, the ET tube always makes the resistance worse, right? It has to. It makes your resistance worse because it's smaller than your trachea. So for me, if they're borderline or even a scooch less than I would want, I just take the tube out because it's going to make it better. They're not going to cough. They can cough their secretions out. You can suction them. You don't need to sedate them anymore. Because the corollary to that is what? You sedate them again because they're coughing. Then what's the goal exactly? So I get the tube out very aggressively, certainly with patients with asthma, patients with COPD also, especially if I don't think there's a big reversible component to it and their time constant's 1. So that means I need 3 seconds of exhalation. If I have 1 second of inhalation, that's 4 second breath to breath time divided by 60. They can't breathe more than 20 or else they're going to fall apart. So your regular tachypnic, anxious dude is going to be breathing 20. So you're always going to be on the cusp of auto peep. So I just take the tube out. And then if I put it back, I don't know, I take the tube out. Same thing with hemoptysis, right? If you're hemoptysizing and you're hypoxic and dying, you need an ET tube, right? But if you're not, it's better to keep them not intubated because they can clear their airway much better than we can clear their airway. So
Mhm.
I to really answer your question, this isn't a box checking SAT SBT protocol, right? This is the intensivist is there. We're going to roll the dice. She looks okay. She's awake enough. She's following some command. The vent looks okay, but not great, but good enough. We think that she's broke her bronchospasm for sure. This is the only time that I actually think auscultating a patient in the intensive care unit matters. I think 99.9% of the time it doesn't matter at all. Everyone has bronchi, everyone has whatever, but this is the time that it matters. So if they have a really good air movement and the vent looks good, they look okay, I'm taking the tube out because it's just going to be easier. It's going to be 1,000% easier at every step. Is that, I don't know. Is there an answer? I don't know if there's an, it's my
No,
answer.
there really is no answer. Again, I agree 100%. And I also, I think, would advocate to put the patient straight to high flow with Aerogen. That would be my
Yes. 100%.
strong suggestion. I would not jump to non-invasive. I'd have it available, but I wouldn't necessarily go to it unless I had to. But with the mucociliary clearance, I want to try to encourage that and get the secretions out.
So
So I would
on
think
on
high
that
flow.
note, mucociliary clearance, I got some interesting blowback from when I said I think 3% saline is BS except for bronchiectasis. Like for this patient, no, because it's a bronchospastic, so that would be insane. But so what would you do for her then? Just like manual chest BT, IPV, what would you do? As from RT sort of if I can I'll ask the
Yeah.
RT, like, what do you guys think?
So, full disclosure, RTs in Canada are not the experts at chest physio. We tap our physiotherapists for that to
Okay,
do all of that
interesting.
stuff. Yes, I will use percussion for patients who I am expecting they're plugging or they have a history of thick secretions. I will do some chest percussion and we'll use the vibrating beds and things. And we have cough assist. I absolutely can use that if I want, but I don't want to throw that on an asthmatic. It's just going to cause anxiety unless they need it. Honestly, I think I would do a lot of passive things as first line and then obviously get the chest physio from
Right.
physio, seeing them as as soon as possible and advocate for that. But I think what my main goals would be optimal heat and optimal humidification. So I want to deliver as much of that as I can to help encourage the cilia to start working again and ensuring that we're not drying things out more than we have been with high
Mm,
flows on events or things like that.
okay.
So with active humidification, that is 100% for me. Even if they don't even need the oxygen, I am putting them on high flow for that purpose because I
Okay.
want to really encourage active body temperature, heat, and humidification.
Interesting. All right. Look at this. Unbelievable. So that's all right. So interesting. And then to round this out, because I think this also happened. So actually, there's a couple things. I do look at all that other stuff, but the thing that really tells me the patient's broke is when the continuous nebs are starting to make them really tachycardic, right? Because they're starting to absorb more of the albuterol. So on that note, when would you start to back off of the bronchodilator? I guess what I mean is, like, let's say the patient's broke, they're broke, whatever that means. And so now, do you go to just Q4 or you go to Q2? Do you really back it off slow, or how do you like? What's your approach?
And I've had a lot of luck with severe asthma situations in Emerge where we're starting, or sorry, I should say for everybody else it isn't in Canada, where I'm dealing with a very severe status situation and then you're doing continuous and then they're
Right,
starting to get better and they're breathing better
right,
and their work things coming down. And then you're starting to say, okay, we're going to try to back off. So going from
right.
continuous to Q30 and doing that for a bit, staying at
Oh,
the
okay.
bedside.
So you go
And
to
then from there,
Q30.
well, if I was going continuous, then the
Okay.
next thing would be Q30. This is the
No,
very acute phase.
no,
And
that's
then
what I'm
from
saying.
there,
No, what I
go
mean is,
to,
we'll go from continuous to like Q2 at the next time point. So that's
oh,
what I'm saying.
wow.
So you go even less aggressive, or
Yes.
I guess more aggressive, however you look at it. All right.
Yeah.
That's why I
In
asked.
the super status phase, I don't leave that patient's bedside until they are at least down to Q1 hour and I have watched them. So whenever I have dealt with a patient that I am trying everything in my power to avoid intubation, they have their own personal RT slash shadow in me. And I do not leave that bedside unless there is an absolute crazy emergency that they absolutely need me for. That is I am there. That is my one priority. And I don't leave until I know beyond a shadow of a doubt we are moving. I've already gone 2 steps with them from continuous to Q30 to 1 hour, and they've been okay. Then I'm saying I will come back in 30 minutes and swing around again. And as long as we're still trending the right direction, then after even two of Q1 hour, then I'll go to Q2, but with 1 hour PRN and whatever.
Interesting. No, that's actually, I think, I gotta be honest with you. I think a lot of people are gonna, well, depending on who it is, and not me, because I am uber aggressive with the albuterol. We use the definitely not continuous to Q1. I think a lot of people go continuous Q2, Q4, then the Q6 thing. That's good to know though, because I think I gives me more fodder to be like, we should go from continuous to, I probably can get RTs to do Q30 to be honest with you, just because of the assignments and stuff, but to Q1 and then sort of back it off more slowly,
Well, at
which,
the end of the day, you could even order it though Q2, but then you're still throwing in your PRN order. And I think
yeah,
if you
it's
have
true.
someone clinically at the bedside and you watch what's actually being given, even if you're writing a Q2 order, which that might be your standard practice and that's fine, but if you're having a Q1
Yeah,
hour PRN, watch and see how often that patient's getting a PRN dose at that hour mark. And you might actually be surprised that they are being treated more aggressively than you think in your order set. And
true.
and especially if someone is at the bedside actively watching this patient and you're watching for signs in your waveforms if they're ventilating or in their work of breathing or in their overall end tidal if they're starting to swing a certain way or whatever you're doing at the end of the day if someone's at the bedside watching they're going to see those micro signs to say like, even asking the patient are you feeling a bit more tight or are you still feeling better and I use that
Yeah.
barometer a lot. I say we need to be working in one solid direction and if you at any point feel like we're going the other way you let me know and we're going to go back to be more aggressive. And so I use the patient to direct. And if they say they're not continuing to feel better, that's a sign, oh, we're backing off too quickly and I want to be more aggressive again.
That's actually really helpful. No, I think you're right. And I think much like diabetes, patients with asthma know. They're like, oh, I don't feel
100%.
right. I'm tight. Yeah. No, it's a lot more. I think sometimes we get a little, not discouraged, but jaded, certainly when older patients and they can't tell you anything. There's no good history. It's just you're trying to figure it out. But not with asthma, certainly. Not with COPD either, honestly. People will tell you, I've been feeling bad for a few days, or I took my albuterol and it's not really doing what it used to do, or something of that, or coughing, or they feel short of breath, or I can't go up the steps anymore. I used to be able to do that. So I do take their symptomatology much more. I don't want to say much more seriously because we take all patient symptomatology very seriously. However, the delirious, demented 99-year-old grandma with sepsis is sort of less of a fountain of information than the 40-year-old patient with asthma who their daughter's sick at home and now they're sick and now they're coughing. They use their Symbicort more. Now they're in the ER. And that's a lot different, I think, from a symptomatology standpoint. So these aren't people that these are definitely not people you can plug into a protocol and just say, whatever, Q2, see you later. You really need to be watching them. And I think the one little plug I'll give is if you've done the things in acute asthma exacerbation and they wound up on BiPAP and they're sort of on BiPAP, it's not like COPD where you trial them off in a couple hours. I leave those patients on for a little bit, a longer time, I think, than maybe normally would or whatever. Like, I really leave them on, give them more treatment for like 12 hours. Then much later, I take them off. I'm a lot more ginger about taking patients off of non-invasive who wound up on it in the midst of an asthma exacerbation because that just harkens that was a really bad one, right? You know what I mean? So I don't know. I see people take patients off BiPAP after a couple hours for asthma. I'm just like, I don't know, man. It makes me a little nervous about it because they tighten back up, right? I've seen them tighten back up in front of my eyes. What do we do? We were like, we had it broke. When you get it broken, it's so important to keep it broke. It's just, I can't explain how
And
important that is,
I
honestly.
think I think that that's the one piece that I'll encourage people, your patient is going to know if they're tightening back up before anything else. And
Yeah,
if you are constantly asking them, are we still exactly the same? Are you feeling any worse? You will catch them way sooner if you are on that and you're asked. And I want to advocate and say, yes, Ventolin can cause tachycardia. All these things can happen. But at the end of the day, it's a very safe medication. There are always side effects. Yes, we have to watch our potassium. Yes, we have to do all these other things. But at the end of the day, it's not a medication that in over 18 years of experience with asthmatics and with treating them, that I have really ever had a negative outcome where I was like, oh, the Ventolin really caused harm.
I
No.
know. I
So
know. And God told me
it's a
that twice.
it's a situation here where you have a patient who has a pathology that will kill them, and there is a treatment plan that if you are more aggressive and you're not maybe stepping it back too quickly and saying, oh, my order's only Q2, I'm just going to wait for my 2 hours. No, if you go in and you ask your patient and they're feeling worse at the 45-minute mark, you get on the phone if you don't have the order and you call your doc and say, my asthmatic patient who has been asthmatic for 35 years is telling me that they are
Yeah.
getting worse again. Are we really going to wait? And I
Yeah.
guarantee you have a PRN order so freaking fast. And coming back to the BiPAP thing, don't sleep on the humidification. Active
Mm.
humidification for your BiPAP, for the love of everything holy. If you use an HME or a passive humidification for these asthmatic patients, you are actively working against them. Active humidification. Thank you. My TED Talk is over.
No, that's like it's good too because like, for me, when I go to the bedside and I'm like, oh, sadly for the RTs, when you say these things, so is the humidification on? They're like, they look at me like I have two heads because why are you asking about that? Because not that they're not doing that or what, but like just everyone knowing a little bit more about everyone else's job, because we're busy, maybe we forget or we're doing other stuff or we didn't get to it yet, or it just keeps everyone on the same page and with the same goals.